Thank you, Drug Science. Great to be on the platform with Meg as well, and thanks to James for organizing all of this. So I've got loads of slides, but we're going to fly through them. I want to start here. You know, it's a difficult, lonely place being a psychiatrist these days. Always has been. Biological psychiatry has overtaken psychiatry over the last 40 years. We have these drug companies queuing up to give us daily maintenance medications. That picture at the top there of leprosy and various infectious diseases. We are in modern psychiatry where we were in general medicine about 100 years ago. Okay, 100 years ago, we were losing the battle to the infectious diseases. We didn't understand microorganisms, we didn't understand infections, and we didn't have antibiotics. We were very good at epidemiology. We knew all about smallpox and tuberculosis and leprosy, but we didn't know how to treat them. And we wrote all these diagnostic manuals. Well, that's where we are in psychiatry. We know all about anxiety, addiction, PTSD, depression, personality disorder, but our treatments are poor because we just have these daily maintenance with these daily drugs you have to take just to mask symptoms every day for weeks, months, years, decades, and the pharmaceutical industry queue up for these, but we don't cure patients, and we don't talk about the cure word. Cure word's almost a dirty word in psychiatry. We just get alongside people in this palliative care way. I think that's not good enough, you know. We've had 100 years of modern psychiatry. We should be curing people. Why can't we be like the orthopedic surgeons? Why can't we mend an ankle and then discharge the patient and never see them again? And most psychiatrists think that's a crazy idea, but why? Why shouldn't we? Well, the reason is because we are not using psychotherapy and psychopharmacology in a smart way. And where is our antibiotic to kill these infectious diseases that are caused by trauma? Well, you can see where we're going. Now, trauma and child maltreatment and abuse underpin pretty much all chronic mental health problems, whether it's big T trauma like physical and sexual abuse, the stuff that hits the social services radar, or whether it's what we call small T trauma, which is not small at all. It's incredibly damaging to a psyche that interrupts a secure attachment relationship. This becomes the blueprint for your life, how you live your relationships, and is fundamentally disturbing to the human psyche and underpins the chronicity of all these mental disorders. And of course, there's a whole host of other factors. All mental health problems, just like all medical problems, are multifactorial. So those of you that work in mental health will know that you work with people on the lowest rung of the ladder. We work with the people from the lower socioeconomic groups with unemployment, poor housing, racism, exclusion, parents with mental illness, accessibility to drugs such as alcohol, which are really bad for you, and less harmful drugs like heroin and cocaine, all of which are hugely damaging. And so it's a stacked up multiple factors that result in chronic mental disorders. And a little bit about the concept of the amygdala and about the concept of trauma. So there's that little area in red there, that's the amygdala, very old part of the mammalian brain. The amygdala does not require any perceptual input. Forgive me, it does not require any upper thought from the cognitive centers. It relies only upon perceptual input. So in response to fear and pain and feeling scared and frightened, your amygdala will fire. It will trigger a autonomic response called fight, flight, freeze, which is a knee-jerk reaction. So as the caregiver comes into the room and the child is frightened and they know that they're going to get kicked, punched, burned with a cigarette or raped, year after year after year, you develop this excessive amygdala response whereby you're overly frightened of things even when the things are not frightening. Now, the green area there is this much more sophisticated part of the brain. So all mammals have an amygdala, everything from a shrew to a giraffe to a dolphin to a cat and a dog and of course a human. Only really humans have this prefrontal cortex, this area in green. This is much more sophisticated, where we use logic and reasoning, and we can overcome the amygdala response with this prefrontal response. Now, if you expose a child to constant frightening experiences, what they do is you have a physical brain change. You actually get a physical change in terms of networks and connectivity, in which they have a hyper amygdala response. Now, I'm starting the talk by just pointing this out because it's really important that we understand this in understanding particularly how MDMA works. So there we have a physical brain damage, if you like, as a result of childhood trauma, in which the prefrontal cortex is shrunken. People who've experienced excessive trauma and maltreatment as a child are not very good at seeing the positives, and they're excessively frightened with that amygdala response. And this results in this identity formation. Now, if you're lucky enough to have a secure attachment where you're loved and cared for and played with and praised and kissed and cuddled, you develop these very positive narratives of self, that you're a good person and achievable, and the world, that people are good and can be trusted and the world is safe. And this is the healthy, positive, secure attachment, which most people have. Now, if you've had an insecure attachment, you develop a very negative sense of self. It's very hard to see the good in things and the good in other people. And in some respects, you see, PTSD can be seen as a sign of a healthy brain. It's a positive neuroadaptive response, PTSD. You wouldn't be healthy if you didn't become excessively frightened, because nobody was looking after you when you were 5 years old. If you didn't become excessively frightened of the world, you're going to die. So you develop this excessive response, which actually keeps you alive, but of course becomes maladaptive as you move into adulthood. And in that situation, the only thing that you can really do is block out the world with, as I said, dangerous substances such as alcohol, and then less dangerous substances, but equally damaging in many ways due to drug prohibition, drugs such as heroin. And this leaves a very difficult position for working with patients with trauma, which is most patients. Now, it's very hard to treat trauma-based disorders, whether it's complex PTSD or single PTSD or addictions, all of which are underlined by traumas. And there's no single drug. We treat them symptomatically. If they can't sleep, give them a hypnotic. If their mood is low, give them an antidepressant. If their mood goes up and down, give them a mood stabilizer. If their hypervigilance spills over into paranoia, this edginess, give them an antipsychotic. So you have this polypharmacy. We have polypsychotherapies as well, all sorts of different psychotherapies, IPT, CAT, CBT, EMDR, trauma-focused psychotherapy, you name it. All of which have the same basic effect, which is, let's talk about your pain. Tell me about your rape. Now, that's very, very difficult for people for whom even thinking about the thought of doing that results in a severe dissociative episode. They flee, they drop out of treatment, they go back to the vodka. So we have high rates of treatment resistance and high rates of substance misuse, and of course, high rates of completed suicide in trauma-based disorders. Now, addictions which are rooted in trauma, actually have their historical roots very much in psychedelics. Most of the work done with LSD in the 50s and early 60s was with alcoholism. And what these studies found was that when patients had this mystical experience, this mind-blowing peak experience, they had this natural abstinence from alcohol. And Terry Krebs and Paul Johansson did a meta-analysis of the work in the 50s to the 70s, and they found a very strong effect size for LSD psychotherapy for alcohol addiction. And this, a lot of people don't know, Bill Wilson, the founder of Alcoholics Anonymous, also had 4 or 5 important LSD experiences. And when he talks about the higher power, he's talking about the LSD experience. Now, it's interesting that Alcoholics Anonymous have kind of erased this from the history of AA, but it really does make sense in terms of the mystico-spiritual aspects of AA, that alcoholism can be cured by a mystical experience induced by LSD. In modern times, Peter Bogenschutz and his team have looked at, in New Mexico, they've looked at the use of psilocybin for alcohol addiction, and we very much based our study on aspects of that when we came to do our Bristol BEMA study. So I want to turn to MDMA, having given you a little bit of background around child abuse and trauma and the history of addictions with psychedelics. 3,4-methylenedioxymethamphetamine, wonderful molecule. Will it work for alcoholism? So the reason we did this was because I'm really interested in big public health problems. I'm not particularly interested in small, rare psychiatric diseases. Although, you know, big respect to Meg and her work with anorexia nervosa. Personally, I'm more interested in working with obesity. 30% of the population of Bristol has obesity. It's about 1 or 2% that might have anorexia nervosa. So we chose alcoholism because it's huge, it's massive. 25+% of the UK population are harmful drinkers, of the adults. But would it work with MDMA? Now, ours was the first ever addiction study with MDMA anywhere in the world. And but what we knew was there was all this work done by MAPS around PTSD, and we knew that alcoholism is underpinned by trauma. So we kind of put two and two together, and we thought it would work. But one thing MDMA seems to lack is this kind of cosmic psychospiritual experience. Around about 5 to 10% of first-time MDMA users will talk about communing with God in a psychospiritual sense, which is nothing like the 80 to 90% that psilocybin and LSD users will say. So we thought it might not work for that reason, because all the work of the past, either the work in the 50s with LSD, or more recently Bogenschutz or Matt Johnson with nicotine addiction and psilocybin, or Krupitsky with ketamine addiction and opiates and alcohol, using ketamine rather for opiates and alcohol, they all found that the more the spiritual experience, the greater the sobriety. So it just might not work. But we did know that MDMA works with trauma and empathy. So that's what led us to put two and two together and see if it would work in our study. So MDMA, if you were going to invent a drug to assist trauma-focused psychotherapy, you would come up with MDMA. It does have this amazing quality: short-acting, incredibly safe, very clinically tolerable, almost always pleasurable, like the opiates, very safe, and this particular ability to access traumatic memories and enhance empathy. Now, MDMA works across multiple receptors. It's much more sophisticated than just increases serotonin, which a lot of people think. It has a increased release of serotonin, which is picked up at the 1A and 1B receptors, which reduce anxiety and depression. Mild effect at the 2A receptors, where the classic psychedelics work, but not anything like to the same extent as LSD and psilocybin. We're not talking melting walls and dripping faces or massive ego dissolution, but we're talking an ability to think outside the box and see things in a new light. Then there's this paradoxical dopamine and adrenaline stimulation in tandem with this alpha-1 and 2 activity, which causes relaxation. And anybody who may have taken the recreational drug ecstasy might be familiar with that peculiar sensation of being both speeded up and slowed down at the same time. Now, within the psychotherapeutic context, this puts you beautifully into this perfect arousal zone. Your level of alertness is increased, and you're motivated to engage in therapy, but you're also you can take the edge off that hypervigilance that often comes with trauma recall. And then, of course, there's this effect at the hypothalamus, a hormonal effect with the increase of oxytocin. Oxytocin is the hormone released from the brains of breastfeeding mothers that engenders a sense of empathy and bonding. So when you add up all these things together, what you've got is this amazing sense of selectively inhibiting the fear response. And it's the selective inhibition of fear that's so important. Many drugs inhibit fear. A bottle of vodka nicely inhibits fear. A bag of heroin beautifully inhibits fear. But they're very messy drugs, those drugs. You can't work on those drugs. You can't talk, you can't reflect. With MDMA, it's just the fear that is so selectively taken. And I always share an anecdote here. I can remember many, many years ago, coming back from a rave, back in the late 80s, before I went to medical school. And we were all lying there, all chilled out and blissed out, and everyone going, "Hey man, it's so beautiful." And somebody said, "Oh wow, let's think of the worst thing in the whole world." And we all lay there, and someone said, "Let's imagine our mums dying." And everyone just lay there like this, then went, "It's not that bad." And that's what's so weird. And I mean, this is before I knew anything about MDMA or MDMA psychotherapy, but that's kind of what we do. It puts the brain into a mental state in which you can reflect upon, talk about, think, challenge, and overcome long-standing narratives that have become stuck. So going back to the earlier slides of these stuck narratives about self, about one's uselessness, how one is bad and terrible and unlovable, these things can be challenged because the fear that maintains those has been dissolved by the MDMA. And here's our traumatized brain with its hyperreactive amygdala, this child who's grown into an adult and now has these physical brain changes and that shrunken prefrontal cortex. Under MDMA, we have a complete reversal of this. It switches off the amygdala and it boosts the prefrontal cortex and allows you to feel good about yourself and think about and reflect in a positive way about one's rigid narratives. The perfect drug for trauma-focused psychotherapy. So we set up this study team. There's David Nutt, who was the CI. I was the PI and lead therapist. alongside Laurie Higbed, and that's Michael Mithofer there, pioneer of MDMA-assisted psychotherapy in the States. And it was an open label safety and tolerability study. No control group, no placebo group, and you might be saying that's not very methodologically sound, Dr. Sessa. Well, it's what you have to do when you do a new drug in a new condition, and it was the first time this has ever been done. You have to do an open label safety and tolerability study. So we had, it looked like this. The patients were all heavy daytime dependent, physically addicted drinkers. They went through a detox, came down to 0 alcohol use, and then they came into this 8-week MDMA course. Much like all psychedelic therapy protocols, it involves both drug and non-drug sessions. So you've got your 2 MDMA-assisted sessions, which were all day, and they're sandwiched between non-drug sessions for preparation and integration and follow-up. Then we followed them up for 3, 6, and 9 months. Now, interestingly, before we did this study, we did a study called the outcome study, in which we did all of the same screening, consent, inclusion, and exclusion factors on a group of patients. Then we didn't give them the MDMA course, but we still followed them up for 3, 6, and 9 months post-detox, just to see how well people are generally doing currently with the very best gold standard treatments for post-alcohol detox. And I'll talk about that in a second. So that's the basic protocol. Now, I love this table because it's so spectacularly boring. It says absolutely nothing, which is exactly what we wanted, because this is the demonstration of the tolerability and safety aspects. No adverse events, no deaths, no suicides, no all positive experiences, no abnormal bloods, no abnormal ECGs. So that's exactly what we wanted to show in our safety and tolerability data. And it is incredibly safe. So firstly, MDMA, clinical MDMA is not recreational ecstasy. I've been talking about ecstasy for 15 years, and I used to put all these graphs and tables up about holes in the brain and neurotoxicity and ecstasy users, whatever they are. I don't bother now. There's so much data on this. The clinical pharmacology community is very clear on the fact that long-term neurotoxicity is just not a thing. It's not happened. There are still a few tragic deaths from MDMA recreationally, none in research. All of those deaths, like all drug deaths, are due to its status as a banned substance, not because of its pharmacology. They could all easily be avoided. Quote of the day: drugs don't kill people, prohibition does. We will hang our heads in shame when we look back on the last 50 years of this extremely bizarre socio-political folly that is the war on drugs and the deaths of people and the production of crime and the funding of the mafia that we've done with this ridiculous policy all over the world. But it is changing. It is changing. Nevertheless, the ethics committee wanted us to look at all of these physiologies. And you see this lovely sort of graph of the blood pressure and pulse go up slightly, hover around, right? It's like a kind of takeoff, plateau and landing type effect. The drug effects go up, the anxiety comes down, temperature and blood pressure and pulse go up slightly, but they all stay within normal limits, no adverse events there. Now, what about come downs? People often ask about this. And there's this kind of anecdotal thing from the raver community of, I don't know what people call it nowadays, Black Monday, Blue Monday, Suicide Wednesday. We did not see it. We did not see it. We measured mood and affect, and we measured suicidality and sleep for 7 days after each MDMA session. These are the pooled results across 26 sessions. Now, this is the POMS scale, which is the profile of mood states. Any negative numbers? So 0, a score of 0 is normal mood. A score of plus above 0 is depression. Anything under 0, negative scores, is not only not depressed, but actually positively felt mood. So what we see here, which is a wonderful result, is a 7-day afterglow effect, which we weren't expecting. And this is what you see with classic psychedelics. So far from Black Monday, Blue Tuesday, whatever, we have an afterglow effect. And just to comment on this, why do we have this narrative of this post-MDMA affect job? I think it's an artifact of raving. It's not the pharmacological effects of MDMA. If you look at how do people take ecstasy, what do? You go to the pub, you drink 3 pints, you take a pill, you go to a club, you take another pill at 2 a.m., you drink a few more pints, you go back to someone's house, you do a line of cocaine, you do a line of speed, you smoke loads of spliffs, you stay up all day Sunday, you drink endless cups of tea, you drink another bottle of wine. If you're lucky, you'll get 2 hours sleep on Sunday night and a cup of soup. And then you go into work on Monday or Tuesday, and then you feel like crap. And then you go, oh man, it's my ecstasy serotonin depletion. It's a bloody hangover. You've been up for 2 nights. You've barely eaten. You've danced all night and you've taken bucket loads of other drugs. We cannot make inferences about clinical MDMA based on recreational ecstasy users. When we give MDMA, the patient comes in after a good night's sleep. They take MDMA at 9:30 in the morning. They're up all day. They're back to baseline by 5 p.m. They sleep like a baby and they feel great for a week. So let's not talk about ecstasy users, whatever they are. So here's the big thing then. How do we do with our drinking behavior? Well, this was not a primary outcome measure. These were secondary outcome measures because it was a safety and tolerability study. But this is the results of the study we did before. So this is where we just took drinkers in Bristol. We measured them all before detox. They all dropped down to 0 at their detox, and without any MDMA intervention, the very best that modern medical science can give to modern drinkers today. This is what we have. Pretty much about 75% of them back to their full levels of drinking by 9 months. So this is, they've had detox, they've had rehab, they've had AA, they've had MAT groups, they've had group therapy, individual therapy, you name it, everything that they can get with modern medicine. And you know what? We were better at treating alcoholism in Victorian times than we are today. This is the sad thing. This is the outcome if you're a drinker in today's society. And there is the outcome from the MDMA-assisted psychotherapy course. Similar spread of patients, heavy daily drinkers before detox, brought them all down to 0 at detox. They then got their 8-week MDMA course, and then by 9 months, that's the outcome. And if we superimpose these 2 graphs, a slightly different scale here. This is the scale of those consuming over 14 units a week, which is like the definition of harmful alcohol use. Now that graph, I'm going to let you hover on that for a second. This is a miraculous result. You do not see graphs like that in human psychopharmacology research these days. If you imagine that was a placebo-controlled study against an SSRI or CBT, these 2 graphs are much, much closer together. A difference there between 21% and 75% is a money shot. That is a superb graph. And it really demonstrates why we need to do more research in this area. This blows out of the water the current very best treatments for alcoholism. And so we're very proud of that outcome. There's a few shots there of our staff team and some qualitative statements from people who took part in the study. Why then, if these drugs are so great, why are we not using them? And these are some of the things that people say as to why we shouldn't be using psychedelics. Swapping one dangerous drug for another, that's absurd. There's nothing more dangerous than drinking a bottle of vodka a day. There's no drug in the pharmacy that's worse than drinking a bottle of vodka a day. That's absurd. Risk of addiction to psychedelics, absolutely absurd. We don't see addictions to psychedelics. You don't see drug-seeking behavior. Nobody robs houses to get some money to buy magic mushrooms or ecstasy. It just doesn't happen. Lack of research of efficacy, rubbish. All of the studies of the last 15 years have been superb. All of the outcomes have been superb. Sends the wrong message. Don't even get me started, Ms. Patel, on the concept of what message we should send. As David said, we should send the truth. Costly and difficult, yes. Erroneous, stigmatizing public perception, yes. And this is why we're being held back. I started doing this work in the 90s when I was a DJ in London. That's when I became exposed to ecstasy. I still DJ. It's a fantastic place in which to work. Get involved. We're still pioneering this. Even if you start now, you are not too late. People are talking about the psychedelic renaissance, I wrote this book 12 years ago, and now we're all talking about this. So please remember my book, go and buy it, because we've now actually eclipsed the work of the 60s. People talk about the psychedelic 60s. We're way past that. There's loads more psychedelic research going on now, loads more people taking psychedelics, and a much better cohesive community of psychedelics than there ever was. I'm immensely proud to have been involved in all these studies with LSD, psilocybin, DMT, MDMA and ketamine. I've received all of these drugs as a test subject, mostly intravenously. A saddening amount of white middle-aged men in these pictures. We need more diversity across the board, but especially in this field. So this just a couple more slides. Here's the future. I'm about to open Europe's first psychedelic clinic here in Bristol. We have a stellar scientific advisory team headed by David and the Mithoffers, and we've got Celia and Matt Johnson from Johns Hopkins. We've got some really, really exciting things coming up with clinics, training, and original research. The building is almost done. I went down there this morning in the snow and it's looking beaut. So it's moved on and we're almost there, opening in the next few weeks. Thank you very much. I shall stop there.